Hello everyone. For today's lesson, we are going to talk about calcium and phosphate metabolism, parathyroid hormone, vitamin D, and bone metabolism. I'm Dr. Ana Angelica Macalalat-Josue and I will be your teacher for today. So the outline of my lecture for today will be the following. So first, we'll talk about an overview of calcium and phosphate regulation. Next, we're going to discuss bone and its relation to the extracellular calcium and phosphate. And then we will proceed to discuss vitamin D, parathyroid hormone, calcitonin, and lastly, your calcitonin. And finally, I'll summarize everything for you. Okay, and we'll also discuss some pathophysiologic states that might help you understand what happens if your physiology of calcium and phosphate and bone metabolism is deranged. So this slide shows the total body distribution of both your calcium and your phosphate. So your calcium is present in 1% of the extracellular fluid and 1% is located intracellularly. And 99 or more than 99% of your calcium is actually stored in the bones so that whenever you need calcium, in an instant, you will be able to mobilize calcium from the bones right away. So this is the distribution of your calcium in the body. 50% will be biologically active in the form of your ionized calcium. 9% will be calcium complexed with anions such as your calcium phosphate, calcium oxalate, no? And then lastly, your protein-bound calcium will be 41% of your calcium in the body. So what's your protein-bound calcium? Usually, this is your calcium is bound to albumin. Phosphate, on the other hand, similarly will be less than 1% in the extracellular fluid. But a bigger chunk of your phosphate, 14 to 15%, will be found intracellularly. Remember that your phosphate is part of your adenosine triphosphate, and even your DNA and your RNA also has phosphate in it. So unlike your calcium, there are more phosphate intracellularly, while 85% of your phosphate is also stored in the bones. So hypocalcemia, if there's very low calcium in the body, causes nervous system excitement and tetany. So your calcium is very important in your nerve physiology. So if there is hypocalcemia or low calcium, there will be an increased neuronal membrane permeability to sodium. No? And because of the increased permeability to sodium, so your sodium will go inside your voltage-gated ion channels more easily and will easily trigger initiation of your action potentials. So less than 50%, when this only happens when your calcium levels in the body is already less than 50% of your normal calcium. When your normal calcium in the body becomes less than 50%, the peripheral nerve fibers become even more excitable and they can discharge nerve impulses spontaneously and can cause tetany. So this is what we call your carpopedal spasm. So your carpopedal spasm, the arms of the patient will have muscle spasm because of the continuous firing of action potentials in the nerve supplying the muscles of the hand, and it would contract like that. That's your carpopedal spasm. Other physical manifestation of hypocalcemia will be your Bostic sign. So you just tap the nerve here, and then your face will twitch like that because your nerve is hyper excitable. In very severe instances, in very severe hypocalcemia, patients can go into seizures or even arrhythmias. No? So it's very dangerous. So it's very important that you understand calcium physiology so that you will know how to treat it. On the other hand, on the other end of the spectrum, you have your hypercalcemia. Your hypercalcemia, on the other hand, will depress your nervous system and your muscle activity. And hypercalcemia, you can, in severe cases, you can see a decrease in the QT interval of the heart or a decrease in the transmission of impulses in your heart. It can also cause lack of appetite and constipation because the nervous system is slowed down. This happens when your calcium level reaches more than 17 milligrams per deciliter. The normal is about around 10. The upper limit of normal is about 10 milligrams per deciliter. If it's very high, the excess calcium can form complexes with your phosphate and form calcium phosphate crystals. And the calcium phosphate crystals will now can precipitate throughout the body. All right. So your serum calcium, the result of the serum calcium is actually a result of an interplay of many factors. It's an interplay of your intestinal absorption. So when you eat, when you drink milk, when you eat broccoli, when you eat anchovies, when you take multivitamins that contain calcium, it will be absorbed in your intestine. And then it's also affected by renal excretion. And finally, bone remodeling. So when you eat again, no, let's say you take the average intake of people will be about 1,000 milligrams per day of calcium. And then 350 milligrams of that will be absorbed into the body through the action of your vitamin D. And out of the 350 milligrams that is absorbed in the body, the extracellular fluid will now, the calcium in your extracellular fluid will be secreted, no, into the GI tract also at approximately 250 milligrams per day. So there will be a net excretion of your calcium through your gut by 900 milligrams per day. So the net absorption from the gut is about just 10%. So in this case, if you took in 1,000 milligrams, you will only be able to absorb 100 milligrams of that, and the rest of the 900 milligrams will be excreted in the feces. And then the kidneys, on the other hand, will through filtration of your blood through your kidneys, about 9,900 milligrams per day of calcium will be filtered in the kidneys, and 9,880 milligrams of that calcium that passes through the kidneys will be reabsorbed through the action of your parathyroid hormone. So essentially, the net excretion of your calcium through your urine will be only 100 milligrams per day. Okay, so if you will see, you excrete 900 milligrams per day in your feces, in your urine, you excrete 100 milligrams, so that's about the same as what you took in, no, orally. Now, your bones also play an important part in the level of your serum calcium. So, approximately 500 milligrams per day of calcium is deposited in your bones through the action, is deposited into your bones, and about if the bone formation is balanced, no, the deposition is equal to resorption. So if 500 milligrams is deposited, 500 milligrams of calcium is also resorbed from the bones through the action of your parathyroid hormone and your vitamin D. And they all they all have an impact on the total calcium that is available in your extracellular fluid. Okay? So note that most of the ingested calcium that you eat no, is normally excreted excreted in the same amount in the feces and in the um, urine. Okay, if in normal physiology, of course. So your calcium balance will be a net balance of the intestinal absorption and your urinary excretion. So for example, you have excessive absorption and you cannot excrete it in the kidneys or in the feces, you will have an increase in calcium levels in your extracellular fluid. If you have low intake of calcium and you have excessive urinary excretion of calcium, then you will have low calcium in your body. Okay? So it's really a balance. So your calcium balance can either be positive or negative. So what are the normal physiologic states that manifests positive calcium balance? So in positive calcium balance, your intestinal calcium absorption is greater than urinary excretion. This is the physiologic states where you need to store more calcium than excreted. So the excess calcium is deposited in growing bone. So usually this happens during from infancy to puberty, no? Where you're still growing bone. So you need the excess calcium from your intestinal calcium absorption in order to form your growing bones, in order to support bone formation. There are also instances where you have negative calcium balance. In negative calcium balance, your intestinal calcium absorption is less than your urinary excretion. In the normal physiologic states, where this occurs is during your pregnancy and lactation. So that's why when a woman gets pregnant and continues to breastfeed after delivery, they are usually advised to take additional calcium supplements, or if not, increase their calcium intake in their diet. So now we'll proceed to discuss the first hormone in our lecture, which is your parathyroid hormone, one of the most important hormones that is central to calcium and phosphate metabolism. So your parathyroid hormones is secreted by your parathyroid gland, and your parathyroid glands are usually four in number, and they are located in the posterior aspect of your thyroid gland. No? So usually they're a little bit yellowish. If you assist if later when you become clerks and interns, you assist during a thyroidectomy, during a thyroidectomy where the surgeon removes the thyroid gland, they are usually, the surgeon usually takes extra precaution, takes extra precaution in identifying and isolating the parathyroid gland in order to avoid inadvertently removing it during the operation. Because if the surgeon inadvertently removes your parathyroid gland, then the patient will have no more sources of parathyroid hormone, and it will be very, and then later you'll understand why. If this happens, if the patient loses his or her parathyroid glands, it will be very devastating for the patient because of the important effects of their parathyroid hormone on calcium metabolism. And we all know that calcium is very important in our cellular processes. No? So, all right. So, what triggers the secretion of your parathyroid hormone? If your extracellular fluid has high levels of calcium, the calcium will now bind to your calcium sensing receptor, the CASR, or your calcium sensing receptor. So your calcium sensing receptor, when calcium attaches to it, it sends, it's activated, and when it's activated, it inhibits the secretion of PTH from your parathyroid. parathyroid cells. No? So if you have high calcium, it will suppress the secretion of your parathyroid hormone. In order to avoid excessive calcium in the body, right? Because your parathyroid hormone will serve to increase intestinal calcium absorption, increase renal calcium reabsorption. No? So in order to prevent further increases in calcium in the body, particularly in your extracellular fluid, the excess calcium will result in inhibition of the release or secretion of PTH from your parathyroid gland. On the other hand, if your body or your extracellular fluid has low calcium levels, then the calcium will not be bound to your calcium sensing receptor, and there will be no inhibition of your PTH secretion. So therefore, your parathyroid cells will continuously secrete PTH, and the PTH will now lead to increases in calcium levels in the body. As I've said, through increase in intestinal and renal reabsorption of calcium. So if you have low calcium, it will trigger the parathyroid gland cells to increase PTH secretion in order to correct the low calcium and normalize the low calcium to normal homeostatic or normal homeostatic levels. So your magnesium can also affect PTH secretion. So if there are mild decreases in your serum magnesium, it will stimulate PTH secretion. On the other hand, no, in patients with very severe decreases in serum magnesium, it will now inhibit PTH secretion. And sometimes, if the PTH is inhibited, no, it will produce symptoms of hypoparathyroidism because of the resultant hypocalcemia. So you'll have symptoms of the things that I mentioned earlier: carpophilia spasm, muscle twitching, tetany, so on and so forth. No? So your magnesium also affects PTH secretion, therefore also affects calcium physiology. Next, so your calcium sensing receptor, as I mentioned earlier, is a receptor in the plasma membrane that is used to monitor the extracellular calcium. That's why it's called a calcium sensing receptor. So it senses the levels of calcium in the extracellular fluid. So again, as I mentioned earlier, so your calcium, and it binds to your calcium sensing receptor, it sends a signal down the line to trigger the release of calcium in your endoplasmic reticulum. And the calcium will now activate your kinase phosphorylation, and the activation of your kinase phosphorylation will now inhibit PTH secretion. And this will also trigger, on the other hand, your vitamin D. The activation of this pathway will cause an increase in vitamin D receptor activation. So your vitamin D receptor activation can reduce PTH synthesis as well. So what are the actions of your PTH in the body? It creates a it coordinates several pathophysiologic processes in order to produce an increase in serum calcium and a decrease in serum phosphate. So PTH, what does it do? It increases serum calcium and decreases serum phosphate. That's the end result. So all of this, no, the end result will be to increase serum calcium and decrease serum phosphate. So that's the action of your PTH. So how does PTH do this? How does your PTH increase serum calcium and decrease serum phosphate. So first, your PTH increases bone resorption, which I'll show you in the next couple of slides how. And your PTH inhibits renal phosphate reabsorption in the proximal tubule. So therefore, if you think of it on the opposite way, no, your PTH actually promotes phosphate excretion. Therefore, it has a phosphaturic effect. It tries to excrete phosphate in your kidneys and prevents phosphate from being reabsorbed. So therefore, if phosphate is not reabsorbed and is excreted into the urine, there will be a resultant decrease in serum phosphate. Next, your PTH also results in an increase in renal calcium reabsorption in the distal tubule and increased intestinal calcium absorption indirectly by stimulating the activation of your vitamin D or your 125 dihydrocholecalciferol in the kidney. So your PTH helps activate your 125 dihydrocholecalciferol in the kidney, and your vitamin D now will help increase or stimulate the increase in intestinal calcium absorption. So it's sort of indirect, no? But the end result, no, the bottom line is the PTH will be able to increase your serum calcium, no? And eventually decrease your serum phosphate, right? So what happens if you have low calcium? If you have low calcium, again, it will be sensed by the calcium sensing receptors in your parathyroid gland cells, and it will release the inhibition of secretion of your PTH, resulting in its secretion. So if there is a secretion in your PTH, there will be elevated PTH level. And what's the action of your PTH again? So again, it increases bone resorption, resulting in increased calcium efflux. In the kidneys, it acts by activating your vitamin D, and your vitamin D will now increase calcium reabsorption in the gut and increase phosphate reabsorption. But the direct action of your PTH on the kidney, on your calcium and phosphate, will be an increase in calcium reabsorption and a decrease in phosphate reabsorption, or corollary to that, increase in phosphate excretion. That's why it's called a phosphaturic hormone. And the end result will be an increase in calcium, in serum calcium, and a decrease in serum phosphate levels because of this action. So your PTH, so likewise your PTH receptor is found in the bones and in the distal tubules in the kidney, but not in the intestine, because its effect on the intestine is negated by your vitamin D. So aside from what I mentioned earlier about the action of PTH on the bone, so it's not just about bone resorption, but your PTH also has a dual function or a dual action on the bone by promoting both bone formation and bone resorption, resulting in bone remodeling. So it has both osteocatabolic or catabolism of bone and osteoanabolic or building of bone. No? So your parathyroid hormone, when it's activated, can increase osteoclast differentiation, resulting in bone resorption. But on the other hand, it can also cause osteoblast differentiation and osteoblast differentiation and a reduction in apoptosis, resulting in bone formation. And the net effect would be bone remodeling. So I mentioned earlier that PTH has a direct action on the bone. So how does PTH act on the bone by stimulating bone resorption of your osteoclast. So your PTH attaches to its receptor in your PTH receptor in your osteoblast. In your the attachment of your PTH to the PTH receptor in the osteoblast will result in the formation of your rankle, no? Or your rank ligand, or your receptor activator for nuclear factor kappa beta ligand, or your rankle. And it also stimulates the release of your macrophage colony stimulating factor. Now, your pre-osteoclast contains the receptor for your rank, so they can bind together, and your receptor for your macrophage colony stimulating factor. So when your rankle from your osteoblast, no, binds to the rank receptor, and your MCSF binds to your MCSF receptor, it will result in differentiation of your pre-osteoclast to your osteoclast. Okay, and your osteoclast will now form ruffled borders. No? The ruffled borders will enable the release of enzymes from your lysosomes and the release of acid, no, from your mature osteoclast. And the acid and the enzyme will now result in bone resorption. No? Now, your osteocytes are actually osteoblasts that have been trapped or encased in the bone matrix during bone tissue production. So they become interconnected, they form a system of interconnected cells that spreads all throughout the bone. Okay, so I hope, please remember how this happens. So I forgot to mention that aside from the formation of rankle and your MCSF, your PTH also inhibits your osteoprotegerine. So your osteoprotegerine is a substance that inhibits the maturation of your pre-osteoclast to your osteoclast. So once your PTH inhibits your osteoprotegerine, it now will help the maturation of your pre-osteoclast to osteoclast, and eventually to a mature osteoclast in order to facilitate bone resorption. Next, we go to your vitamin D. So your vitamin D usually makes, your body usually makes vitamin D after exposure to your UV rays from the sun. But aside from being exposed to vitamin D from the sun, there are also other sources of vitamin D, such as your dairy, milk, fortified milk, healthy cereals, and even your fatty fish. Sometimes, no, you can also get it from multivitamins, no? But going out into the sun very early in the morning can help you gain vitamin D. So what does your vitamin D do? Vitamin D provides calcium and phosphate to the extracellular fluid for bone mineralization or bone formation. If there's vitamin D deficiency in children, it usually manifests as rickets. In adults, it usually manifests as osteomalacia. So how does vitamin D affect calcium? What does it do to our body? So your vitamin D is absorbed the exposure to the UV rays will result in the formation of your cholecalciferol or your vitamin D3, and your cholecalciferol will be hydroxylated in your liver first, no? And become your 25 hydrocholecalciferol through the action of your 25 hydroxylase. And this is the major storage form of your vitamin D, your 25 hydroxycholecalciferol. Through the action of your parathyroid hormone, your 25 hydrocholecalciferol will be activated in the kidney to become 125 dihydrocholecalciferol. Your 125 dihydrocholecalciferol is now called activated vitamin D. And it is this one that acts on your intestinal epithelium in order to facilitate calcium absorption in the intestine. No? So it stimulates your calcium binding protein, your calcium stimulated ATPase, and your alkaline phosphatase, and they all work together in order to absorb calcium in the gut. No? And when you absorb calcium in the gut, it will result in increase in plasma ion concentration. And when there's an increase in calcium, it will now send a negative feedback to your parathyroid gland in order to reduce parathyroid hormone levels in order to prevent further activation of your vitamin D and prevent further absorption and increases in your plasma calcium ion concentration in order to keep things in check. Okay? So, aside from increasing plasma calcium ion concentration, by increasing intestinal absorption of calcium, it also increases intestinal absorption of phosphate as well. So this is a patient of mine. No? This photo was taken with permission. Who presented to us because of bone deformities. She had multiple fractures, no, several times prior to consult out our general endocrinology clinic. She had some loss of height, multiple fractures, and some bone deformities. And when we worked her up, we noted that her vitamin D, no, was very, 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 very low, resulting in osteomalacia. So I'd just like to emphasize this because if you understand this, you will be able to master vitamin D. No? Again, so your body has your 7-dehydrocholesterol. And when you're exposed to the sun, it is converted into your cholecalciferol. If you're not exposed to the sun, you can get it from food sources, such as your food, like your fatty fish, your cheese, your dairy. And this will be in the form of ergocholecalciferol, no? Plant-based source of your vitamin D. So your cholecalciferol and your ergocholecalciferol is converted into your 25-hydroxycholecalciferol in the liver through the action of your 25-hydroxylase. And your 25-hydroxylase is the major storage form of your vitamin D. And now, when your PTH acts on your kidneys, it activates your 25-hydroxycholecalciferol to become 125-dihydrocholecalciferol, or your activated vitamin D, or what we call calcitriol. And this is through the action of the enzyme 1-alpha hydroxylase. So your 1-alpha hydroxylase is increased by low serum calcium levels, increased PTH levels, and low serum phosphate levels. No? So when there is a decrease in serum calcium levels and a decrease in serum phosphate levels, it will now result in activation of your 1-alpha hydroxylase in order to activate vitamin D. And the activated vitamin D will now serve to increase your calcium, no? It will now serve to increase your calcium and increase your serum phosphate back to normal, no? And your PTH, so when there's a decrease in serum calcium, it also raises your PTH, and your PTH will now also increase your calcium. So the net effect will be to increase your calcium levels. Right? So next, we go to the actions of your activated vitamin D. So as I mentioned earlier, the net effect will be to increase intestinal calcium absorption, increase intestinal phosphate absorption in order to provide materials for bone formation, no? And then in the kidneys, your vitamin D also facilitates increased renal reabsorption of calcium. So your activated vitamin D increases absorption both in the gut and in the kidneys of both calcium and phosphate. So the net effect will be to increase your calcium and increase your phosphate through the kidneys and the intestine. And it also promotes bone resorption, which provides calcium and phosphate from old bone to mineralize or form new bone. So to tie up everything all together, your PTH net effect will be to increase your calcium and lower down your phosphate. Okay? I've already explained this several times already. Your So let me just continue. Sorry for the interruption. So again, your PTH net effect will be to increase your calcium levels and lower your phosphate levels because it's a phosphatouric hormone. Your activated vitamin D, on the other hand, will increase calcium and phosphate reabsorption in both the intestine and the kidneys and will result in a net effect of increased calcium and increased phosphate. So there's a difference. That's the difference between your PTH and your vitamin D. Lastly, we're going to discuss your calcitonin. So your calcitonin is a hormone that is synthesized and secreted by the parafollicular cells of the thyroid. So this time, the gland involved is your thyroid gland. These are the parafollicular cells are cells interspersed between your thyroid follicular cells. And your calcitonin is secreted in response to an increase in serum calcium because it helps lower down your calcium levels. So, but although the role of calcitonin in calcium physiology in humans is not very big, no? It doesn't have a very, very big impact on calcium metabolism in humans. In lower forms of mammals, it plays a more important role. But your calcitonin has also been um, um, used, especially your salmon calcitonin or calcitonin from your salmon has been um, utilized, no, as a medicine to help lower down serum calcium in patients with very high calcium levels or those with hypercalcemia. So it acts primarily to inhibit bone resorption, and can also, and as I mentioned, it can be used to treat hyperglycemia in order to lower down the increase in serum calcium level. So how does it do that? So when there is a hypercalcemia or rising calcium level, there's an imbalance. Now your thyroid gland releases calcitonin from your parafollicular cells, and your calcitonin now will stimulate calcium deposition in the bone, no? In order to use up the excess calcium in the blood. And it reduces calcium reuptake in the kidneys. No? So if it deposits in the bone, reduces calcium uptake, the net result will be a fall in your blood calcium in order to normalize it to homeostatic levels. No? If there is a low calcium level, what will happen? Remember that your low calcium levels will be sensed by your calcium sensing receptor. It will not be sensed by your calcium sensing receptor because the calcium will not attach. No? And though this will result in secretion of your parathyroid hormone from your parathyroid gland, and your PTH or your parathyroid hormone will now increase again calcium reabsorption in the kidneys and activate your vitamin D in order to increase intestinal and renal reabsorption of the calcium in order to raise the calcium levels back to normal calcium levels. So hypercalcemia, high calcium, calcitonin, to a lesser extent in humans. Low calcium, no, there will be increase in PTH in order to. So to summarize the different hormones that we talked about that regulate calcium absorption, the stimulus for secretion of your PTH will be a slow serum calcium, and the action in the bone will be to increase calcium, calcium reabsorption and decrease phosphate reabsorption or increase phosphate excretion. It's a phosphaturic hormone. In the intestines, it serves to increase calcium absorption by activating vitamin D. The overall effect will be an increase in serum calcium and a reduction in your serum phosphate. On the other hand, your vitamin D, what triggers it is a low serum calcium level, an increase in PTH, no? And a low serum phosphate. So what does it do in the bone? It increases resorption in order to form, it increases resorption of your calcium and phosphate in order to form or mineralize new bone from old bone. In the kidneys, it increases phosphate reabsorption and it also increases calcium reabsorption and calcium absorption in the intestine and in the kidneys. The net effect will be an increase in calcium and a lowering of your serum phosphate. Your calcitonin, the trigger is your increased serum calcium. Increased serum calcium and your calcitonin will now help lower down your serum calcium by decreasing resorption in the bone or promoting bone calcium deposition in the bone. And the net effect will be a reduction in your serum calcium back to normal levels. So let's just discuss few pathophysiologic states where your PTH is deranged. So for example, in primary hyperparathyroidism, there is an elevated PTH. Usually it's because of a parathyroid adenoma. Parathyroid adenoma, it's a mass, no? Hyperplastic cells in your parathyroid gland, and it causes increase or excessive production of your PTH. And because of that, the excessive PTH will increase the levels of your vitamin D. Because remember, your PTH stimulates the 1-alpha hydroxylase enzyme, and your 1-alpha hydroxylase enzyme is the one that is responsible for activating your vitamin D. So the net result, remember the figure about bone mineralization. When your excessive PTH activates PTH receptors in your bone, it will increase bone resorption. That's why patients with primary hyperparathyroidism are very prone to osteoporosis. And in the kidneys, it promotes phosphate excretion. Remember, it's a phosphaturic hormone. And there is an increase in calcium excretion also because of the excessive calcium load of the kidneys because of the hypercalcemia. And there is an increase in urinary cyclic AMP. The net result will be hypercalcemia and hypophosphatemia. In humoral hypercalcemia of malignancy, the malignant cells, usually it's breast, but other malignancy can also cause humoral hypercalcemia of malignancy. There is excessive excretion of your PTH related protein. It acts like PTH, and because it acts on PTH, it also increases bone resorption, increases phosphate excretion, much like PTH, and increases calcium and lowers bone phosphate. So if there is an increased calcium, it will now, remember, there's an increase in calcium. It will now attach to your calcium sensing receptor and work to inhibit secretion of your PTH to prevent further increases in calcium. But of course, you have an unchecked PTHRP, so you will have more increase in serum calcium, but you will have low PTH levels. In surgical hypoparathyroidism, when during thyroidectomy, your parathyroid glands are inadvertently removed by your surgeon, you will have no more sources of PTH. And if you have no more PTH, it will result in, it will not be able to activate vitamin D in the kidneys. So therefore, you will have decreased bone resorption, and there will be decrease in phosphate excretion. So because the opposite of phosphaturic, there will be phosphate reabsorption. There will be decrease in urinary citrate A and P, and the end result will be low serum calcium and increase in serum phosphate. So it's the opposite, of primary hyperparathyroidism. In hypoparathyroidism, there's actually a defective G protein. No? So we don't need to think about that anymore. This is very, very rare. Lastly, in patients with chronic renal failure, your kidneys are no longer functioning well. So if your kidneys is no longer functioning well, your kidneys is unable to produce or to activate vitamin D. No? If you don't have activated vitamin D, what will it do? You will not be able to absorb calcium in both the intestine and in the kidney. So you will have low serum calcium and low serum calcium and increase in serum phosphate. And because of the low serum calcium levels, this will now trigger the increase of your PTH. So you can have, eventually, if this becomes chronic, there will be chronic hypocalcemia, and there will be resultant increase in PTH in an attempt to increase the serum calcium, but of course it cannot because the kidneys no longer activate vitamin D. You can have secondary hyperparathyroidism because of the chronic hypocalcemia from the chronic renal failure. Okay, so that's the end. So I hope I was able to simplify the concepts for you guys. If you have any questions, just send me a message, post comments in the YouTube channel, or post a message in our MS Teams or in our Moodle. All right? So good luck on your exam. Bye-bye.